Thank you for this kind invitation to this important meeting. Allow me to share my slides. I've been asked to speak about the health of children and youth in Malaysia and their needs. And there's a QR code here. I'm going to share quite a bit of information, and I have a number of documents for you that may be useful, especially the first four, which focus on the specific health needs that I'm going to talk about. The link to this is also available with the organizers. Now, we're talking here about 30% of our children, 30% of the population, which is children aged 0 to 18. If you look at, first of all, one of the key problems we're having is a stagnation of our mortality rates for the last 20 years. And the reason we are stagnated is a poor development of inpatient services for children, especially intensive care. If you look at the cause of death of children, a large proportion of them, almost 50% of them, are due to prematurity and then congenital abnormalities. And this requires intensive care. But our services for children in the country have not developed on par with those of adults. And this is not just pediatric intensive care or neonatal intensive care, but also the tertiary services. So if we want to make significant change, we need to grow the intensive care services in our country in line with acceptable norms. Don't forget pediatric nursing, and we need to accelerate tertiary specialty services for children. Another area that we are poor at in inpatient services is inpatient services for adolescents. They amount to about 15% of the population, but currently we treat them like adults, and we have a 12-year-old in the ward with a 70-year-old who's dying, which is totally inappropriate. And we must reflect the fact that these children, our policies must reflect that these children, these adolescents are children under 18, and they need appropriate services, both inpatient and clinic services, and appropriately trained staff to manage them. So I wanted to say for both these first 2 points, we need a life course perspective on health. And that means we think about antenatal, very important area, neonatal, children, adolescent, adult, and elderly, and think of the specific health needs for each of this area and plan for these health needs appropriately. The third area I'm talking about here is the development of services for indigenous children, Orang Aslis and Penans in particular, and their health services have not, their health status has not significantly changed unlike the general population. Poverty remains very high, malnutrition rates are enormous at 60 to 70%, and their mortality rates are very high compared to the rest of us. If you look at our mortality rates overall, neonatal and pediatric mortality rates, we look pretty good. Our under 5 mortality rate looks good, especially when we compare with our region. We've met our SDG targets. But when you look at disaggregated data, mortality rates by ethnic group, you can see that Orang Asli mortality is 11 times that of the national mortality, which is enormous. Even the indigenous in Sabah and Sarawak have almost a 2 times mortality rate compared to the national mortality rate, not to mention the mortality rate of our migrant workers. Much of this is preventable. So disaggregated data shows us that we are not meeting the needs of these individuals. So we need culturally and acceptable and sensitive health strategies for these communities. In Perak, 2 things that we've been doing is establishing refeeding centers in villages, actually feeding every under 5 child with a high energy food meal once a day. And this initiative alone has dropped our mortality by 90%. The second initiative we're doing is taking out a pregnant woman late in pregnancy and keeping her until she delivers and with her child for another 2 weeks before sending her back. And this dramatically drops perinatal mortality. Another issue that we have, which is also linked with poverty, is the poverty focus on the poor in the inner cities and in Sabah. These are children who live in poverty. It's estimated that 3 to 4 million of our children live in relative poverty in our country. And much of their health needs are not adequately met. Their private health services are not something that they can access. And if you want to deal with them, we need disaggregated data. We need to actually make this publicly available as well. We then need to map these communities with the highest mortality and morbidity. We need compulsory mandated medical certification of deaths by law, and we need a decentralization of services and manpower that meet the inner city poor and the poor in rural Sabah. So for both of these 2 groups, the indigenous and the children who live in poverty, we need to reverse the inverse care law. The inverse care law is one where those who need healthcare the most are the ones least likely to get it. And so we need to reverse this and target marginalized communities specifically. And for this, disaggregated data is critical. So we mustn't have achieve health goals in terms of a national average, but achieve health goals for all children, regardless of their status. The fifth area is looking at the healthcare of migrants, refugees, and stateless children. We have failed these children. They have very limited access to hospital specialized care. They have very limited access to primary basic health care, despite this being a legal requirement under the UNCRC and our own Child Act. I think that we need to work to readdress this. We need to bring universal health care services to all children, making inpatient and outpatient care, as well as primary health care, free for all children. Okay? I think to ensure universal access to healthcare for all children in Malaysia, we need a rights-based approach as outlined in the UNCRC. I'd like to say here that if we neglect some of our children in Malaysia, we will fail all children in Malaysia. A sixth area I'd like to focus you on is three big areas that are neglected, either in morbidity and mortality. There's child abuse, there's disability, and injuries. Child abuse is huge. At least 1 in 10 children is sexually abused. Our current services are very poor. We have a good Child Act, but it's not often used to protect children, and we must retrain our healthcare professionals to use the Child Act adequately to protect children, as well as work on prevention programs for this problem. Disability amounts to 15% of all children and about 50% of all specialty clinic visits. Our current screening programs are poor. Doctors are poorly trained in university to assess and identify these children, and rural communities are receive poor access to services. We need to plan for this. We need to fund MOH to organize services for this 15% of our children, and medical universities need to dramatically improve their curriculum, and we need outreach to rural areas. Injury is a huge area, neglected. We have about 1,500 pediatric deaths, children deaths every year, mainly on the road and drowning, and 4 times as many become disabled because of their injury. This is neglected at the present moment with hardly any emphasis on funding. There are many good evidence-based initiatives that work, and we need to put them in place. Again, focusing on injuries, if you look at deaths for children aged 1 to 18, the primary cause of death, 60% of them is injuries, either road or drowning, and we have yet to begin to address this. If you like a comparison, for 1 child that dies of dengue, 30 will die on the road and 10 will die of drowning. And we have spent a lot of money, hundreds of millions of ringgit on dengue, but hardly any initiatives on road and drowning deaths. So we need to bring this focus of prevention into our readdress healthcare plan. I'd like to say here that if you want to address child health needs within an evidence and data-based approach, and areas with large health burdens must not be neglected. The 7th area is psychosocial and lifestyle-related adult illnesses. These are illnesses that happen to children, or problems that happen to children that end up with our huge NCD burden right now, where 1 in 3 adults have either hypertension or obese or diabetes and so on. And if you look at the NHMS studies that we have got, 1 in 10 children currently uses alcohol, 1 in 5 boys smoke, 3 to 4% are on drugs, that 7 to 10% had sex, 1 in 5 are depressed, many are internet addicted, and there's an overweight and obesity crisis that we are facing. This is an important area to focus, not an easy area to focus at all. Together with that, we have the problem with COVID, which has pushed children into a poverty spiral, worsening our childhood malnutrition, and the growing threat of climate emergency. WHO estimates that 25% of all childhood death and morbidity is due to climate problems at the present moment. And this climate emergency threatens to engulf and reverse all our health gains. If we want to work on psychosocial and lifestyle-related illnesses, as well as the impact of climate emergency, the best way to move forward is not with education, but with environmental and citywide change. And this means investing in mobility, cheap, efficient electrical bus rapid transport system with walking and cycling, with a severe restriction in cars. And secondly, to promote 30% of all our inner city, all our city space to become recreational and green lungs. Health is not possible in isolation. We need environmental change. We need significant change in environment and mobility to impact long-term change. And we need our leaders to start using public transport systems so that the rest of the public will use them as well. So developing healthy environments is crucial for psychosocial and for environmental problems. I'd like to end with a couple of points. I'd like to say that we are currently an addicted curative services, addicted to our specialists in the drug-based illness service with a huge focus on specialist care. We need to move it away to a huge focus on childcare, a smaller focus on specialist care. And we need to move our specialists out into the community to impact prevention. So this perhaps may be motivating and retraining them. Part of this can be achieved by not building new buildings, but focusing on mobility for our health services and promote mobile health services is very important. And lastly, I think currently a lot of our focus, a lot of our energy is on hospital care and some of it on health, outpatient and health center care, but we need to move past that to where health really happens, which is in the community centers, in NGOs, in the home. So we need to move away from a mindset of delivery of healthcare to the community towards developing the capability within the community for self-care. And this means empowering. Thank you very much for listening to me.